Urinary incontinence. Urinary incontinence is defined as any involuntary leakage of urine. It may occur in patients with a normal urinary tract as the result of dementia or poor mobility, or transiently during an acute illness or hospitalization, especially in older people. The prevalence of any form of incontinence in all females is 25 to 45%, with a concomitant socio-economic burden. Childbirth, hysterectomy, obesity, recurrent UTIs, smoking, caffeine, and constipation are risk factors for incontinence. Now, pathophysiology. As urine accumulates in the bladder during the storage phase, the sphincter tone gradually increases, but there are no significant changes in vesical pressure, detrusor pressure, or intra-abdominal pressure. During voiding, intravesical pressure increases as a result of detrusor contraction and the sphincter relaxes, allowing urine to flow from the bladder until it is empty. Clinical disorders associated with incontinence are connected with various abnormalities in this cycle, and these are discussed in more detail below. Stress incontinence. This occurs because passive bladder pressure exceeds the urethral pressure, due either to poor pelvic floor support or a weak urethral sphincter. Usually, there is an element of both these factors. Stress incontinence is very common in women and seen most frequently following childbirth. It is rare in men and usually follows surgery to the prostate. The presentation is with incontinence during coughing, sneezing, or exertion. In women, perineal inspection may reveal leakage of urine when the patient coughs. Urge incontinence. This usually occurs because of detrusor overactivity, which produces an increased bladder pressure that overcomes the urethral sphincter. Urgency with or without incontinence may also be driven by hypersensitive bladder resulting from UTI or a bladder stone. Detrusor overactivity is usually idiopathic. Other than in patients with neurological conditions such as spina bifida or multiple sclerosis, in whom it is neurogenic. The incidence of urge incontinence increases with age, occurring in 10 to 15% of the population aged over 65 years, and in approximately 50% of patients requiring nursing home care. It is also seen in men with lower urinary tract obstruction and most often remits after the obstruction is relieved. Now, incontinence in old age. Prevalence. Urinary incontinence affects 15% of women and 10% of men aged over 65 years. Cause. Incontinence may be transient and due to delirium, urinary infection, medications such as diuretics, fecal infection, or restricted mobility, and this should be treated before embarking on further specific investigation. Detrusor overactivity. Established incontinence in old age is most commonly due to detrusor overactivity, which may be caused by damage to central inhibitory centers or local detrusor muscle abnormalities. Catheterization. Poor manual dexterity or cognitive impairment may necessitate the help of a carer to assist with intermittent catheterization. Now, continual incontinence. This is suggestive of a fistula, usually between the bladder and vagina, vesicovagina, or the ureter and vagina, ureterovagina. It is most common following gynecological surgery, but is also seen in patients with gynecological malignancy or post-radiotherapy. In parts of the world where obstetric services are scarce, prolonged obstructed labor can be a common cause of vesicovaginal fistula. Continual incontinence may also be seen in infants with congenital ectopic ureters. Occasionally, stress incontinence is so severe that the patient leaks continuously. Now, overflow incontinence. This occurs when the bladder becomes chronically over-distended and may lead to AKI, high pressure chronic urinary retention. It is most commonly seen in men with benign prostatic enlargement or bladder neck obstruction, but may arise in either sex as a result of failure of the detrusor muscle. Atonic bladder. The latter may be idiopathic, but more commonly is the result of damage to the pelvic nerves, either from surgery, commonly hysterectomy or rectal excision, trauma or infection, or from compression of the chorda equina by disc prolapse, trauma or tumor. Incontinence due to prostatic enlargement can be regarded as a type of overflow incontinence. Now, post-micturition dribble. This is very common in man, even in the relatively young. It is due to a small amount of urine becoming trapped in the U-band of the bulbar urethra, which leaks out when the patient moves. Post-micturition dribble is more pronounced if associated with a urethral diverticulum or urethral stricture. It may occur in women with a urethral diverticulum and may mimic stress incontinence. Now, clinical features. Patients should be encouraged to keep a voiding diary, including the measured volume voided, frequency of voiding, and note of incontinence pad usage, precipitating factors, and associated features such as urgency, since this can be of diagnostic value. Structured questionnaires may help objectively quantify symptoms. The patient should be assessed for evidence of cognitive impairment and impaired mobility. A neurological assessment should be performed to detect disorders such as multiple sclerosis that may affect the nervous supply of the bladder, and the lumbar spine should be inspected for features of spina bifida, occulta. Perineal sensation and anal sphincter tone should be assessed. Rectal examination is needed to assess the prostate in man and to exclude fecal infection as a cause of incontinence. Genital examination should be done to identify phimosis or paraphimosis in man, and vaginal mucosal atrophy, cystocele or rectocele in women. Now, investigations. Urinalysis and culture should be performed in all patients. Ultrasound examination can be helpful in identifying patients with overflow incontinence who have incomplete bladder emptying, as they may reveal a significant amount of fluid in the bladder. More than 100 ml post-micturition. Urine flow rates and full urodynamic assessment by cystometrography may be required to diagnose the type of incontinence and are indicated in selected cases when the diagnosis is unclear on clinical grounds. A CT scan and cystoscopy should be performed in patients with continual incontinence who are suspected of having a fistula. Imaging with MRI is indicated when a urethral diverticulum is suspected. Now, management. Weight reduction in obese patients will aid resolution of incontinence. Women with stress incontinence respond well to physiotherapy. The mainstay of treatment for urge incontinence is bladder retraining, which involves teaching patients to hold more urine voluntarily in their bladder, assisted by anticholinergic medication. Surgery may be required in patients who have severe daytime incontinence despite conservative treatment. The treatment of incontinence secondary to fistula formation is surgical. Patients with overflow incontinence due to bladder obstruction should be treated surgically or with long-term catheterization, intermittent or continuous. Incontinence secondary to neurological diseases can be managed by intermittent self-catheterization.